Hello, PA students. This is Rebecca Basham. I am a PA. I've been a PA for over a decade. I've worked in emergency medicine, family medicine, PA education, and academia. I'm the founder and creator of All Things PAC, which includes resources like our Qbank, our review course called PANCE Points, and the All Things PAC PANCE Review, which you are watching right now. We are going to get started today with our first topic, cardiomyopathy. We're going to cover all the basics. We're going to cover pearls. We're going to go over some practice questions. We're going to make sure that you're confidently going to be able to understand and answer any question about cardiomyopathy that you will see on the PANCE. Let's get started. Before we get started, I'm going to give you a couple of practice questions. We'll read over them and just test yourself, see how well you do. Then after the review, we're going to go over the questions again, and you're going to see how much more confident you feel. Question 1. A 62-year-old woman with a history of amyloidosis presents with a 6-month history of progressive shortness of breath and swelling in her legs. She denies chest pain but notes fatigue and abdominal fullness. On exam, blood pressure is 128/78, heart rate is 84 beats per minute, and respiratory rate is 18 breaths per minute. Jugular venous distension is present, lungs are clear, and there's bilateral pitting edema. Cardiac auscultation reveals an S4 gallop. Echocardiography shows normal ejection fraction, biatrial enlargement, and thickened ventricular walls with impaired systolic filling. Which of the following is the most likely diagnosis? Aortic stenosis, constrictive pericarditis, heart failure with preserved ejection fraction, restrictive cardiomyopathy, or right ventricular infarction? A 19-year-old male college basketball player collapses during a game. Bystanders initiate CPR and return of spontaneous circulation is achieved after 2 minutes. He is transported to the emergency department where he is now alert and oriented. His father reports that a paternal uncle died suddenly at age 25 while jogging. Physical exam reveals a harsh mid-systolic murmur at the left lower sternal border that increases in intensity with Valsalva maneuver. Which of the following is the most appropriate next step in management? ACE inhibitor, beta blocker, high intensity statin, long acting nitrate, or loop diuretic? And our last question. A 29-year-old woman presents with progressive shortness of breath, orthopnea, and bilateral ankle swelling 3 weeks after delivering a healthy infant. She has no prior history of heart disease. On exam, her blood pressure is 110/70, heart rate is 96 beats per minute, and respiratory rate is 18 breaths per minute. Bibasilar crackles are present, and there is an S3 gallop. Which of the following echocardiographic findings is most likely to be seen? Asymmetric septal hypertrophy with preserved ejection fraction, concentric ventricular wall thickening with biatrial enlargement, dilated ventricular chambers with reduced ejection fraction, pericardial thickening with preserved ejection fraction, or regional wall motion abnormalities with normal chamber size. All right, if those are a little intimidating, don't worry. I know you're going to feel better about them after the review. Let's first just take a look at the word cardiomyopathy. You have cardio, which means heart, and you have myopathy, which means disease of muscle tissue. So, cardiomyopathy is just disease of the cardiac muscle tissue. If you remember your physiology, these mechanisms should ring a bell. Preload is how much blood fills the ventricle before the squeeze or contraction. Think of stuffing a suitcase. The more you stuff it, the more pressure there is. And you can pack that thing pretty full, but at some point, if you fill it too much, the zipper's going to burst, right? It can only handle so much. Contractility is how strong that squeeze is. A healthy heart can push hard, but a weak heart may not pump much blood at all. Imagine squeezing a stress ball. If you're feeling strong, you can get a nice squeeze on it. But if you're tired, sick, or your myocardium is shot, your heart's like, that's all I've got. Afterload is the resistance the heart has to push against. Think about opening a swinging door. Generally, you don't have to push very hard. But now think about opening that door if someone was on the other side pushing against it. If the heart is always having to work hard, over time, that extra strain can make it thick, stiff, and tired. And output is simply how much blood leaves the heart with each beat, which is really what matters. If the output is too low, the body can't receive the oxygen it needs. And on the PANCE, when they describe a heart problem, like a big floppy heart, a stiff, thick wall, or a stressed out ventricle, they're really telling you which one of these steps is messed up. And the problems, which ultimately affect the cardiac output, are you either can't squeeze it, you can't fill it, or both. The NCCPA PANCE Blueprint includes the 4 types of cardiomyopathy, including dilated, hypertrophic, restrictive, and the newest blueprint has added stress or Takotsubo cardiomyopathy. And you can think of these as 4 different ways that the pump can be failing. Another way you can think of these, which might be a little easier to understand, is big, thick, stiff, and stressed. And we're going to take a look at each one in a little bit more detail. All right, the first one we're going to look at is dilated. And if you remember, the easy way to remember that one is big. And you can see that in the picture where on the left you have a normal heart, but on the right that ventricle is dilated. The muscle fibers have been stretched out and it looks like a blown up balloon. And when it fills with blood, it's like our overstuffed suitcase. All right, let's look at some pearls for dilated. First of all, it's the most common type of cardiomyopathy. It is also the most common reason for a heart transplant. Its causes include idiopathic, and that is the most common cause, but other causes include viral, genetic, excessive alcohol consumption, and actually, that is commonly used in scenarios on PANCE questions in the vignette. Also, postpartum and cardiovascular disease. Another pearl to remember is that it will lead to systolic dysfunction, and that systolic dysfunction causes a decreased ejection fraction. And if you remember, ejection fraction is the percentage of blood the ventricle pumps out with each heartbeat, and normal is around 50 to 70%. An S3 heart sound may be present, and that's caused by the rapid rush of blood into the dilated ventricle during the filling phase of the cardiac cycle. Next, we're going to talk about hypertrophic or the thick cardiomyopathy, which you can see clearly in this picture. The cardiac muscle is big and hypertrophied. When the muscle is thick like that, especially the septal muscle, it can obstruct blood flow out of the heart, what we call outflow obstruction. And we look at hypertrophic cardiomyopathy as either obstructive or non obstructive. The thick muscle can also make it harder for the heart to relax and fill with blood. Since it can't relax during filling, it causes diastolic dysfunction. So remember, while dilated cardiomyopathy causes systolic dysfunction, hypertrophic cardiomyopathy causes diastolic dysfunction. Some other important pearls are there's a strong genetic component. So any family history of sudden cardiac death should raise suspicion for hypertrophic cardiomyopathy. Also, remember, as far as a clinical vignette in a PANCE question, young athletes with sudden cardiac death, you should be thinking hypertrophic cardiomyopathy. And lastly, the murmur associated with hypertrophic cardiomyopathy, and you know they love to put a murmur in a vignette, is a harsh systolic murmur. And that murmur is going to increase with Valsalva or standing and decrease with squatting. Our next type is restrictive or stiff. You don't appreciate a lot in the picture because the ventricle isn't significantly enlarged and the muscle isn't overly hypertrophied. But what's going on is the muscle tissue is very tight. Think about blowing up a regular latex balloon. Now think about blowing up a balloon made of rubber. That's a little weird, but you can imagine how much more resistant or less elastic the rubber would be, and it would be harder to blow up and expand. This resistance and rigidity in the muscle tissue impairs its ability to fill adequately. So while it may be able to pump blood effectively, the decreased preload ultimately reduces the cardiac output. Because restrictive cardiomyopathy impairs the ability to fill, it also creates diastolic dysfunction. In fact, there is usually a near normal ejection fraction. Now, as the disease progresses, the restriction also impairs the ability to pump effectively and can eventually cause systolic dysfunction as well. But remember, it's primarily associated with diastolic dysfunction. Restrictive cardiomyopathy makes up only 5% of cardiomyopathies, making it the least common. It's commonly caused by and associated with infiltrative diseases like amyloidosis, sarcoidosis, and hemochromatosis. In these conditions, these substances like amyloid proteins and amyloidosis, granulomas and sarcoidosis, and iron and hemochromatosis will actually deposit into the muscle tissue, making it stiff and rigid. Our final category is Takotsubo or stress cardiomyopathy. You might also hear this referred to as broken heart syndrome. That's because it's a stress induced cardiomyopathy defined as an abrupt onset of left ventricular dysfunction in response to a severe emotional or physiological stress. It's thought that a surge of catecholamines like adrenaline brought on by the stress cause a vasoconstriction of the coronary arteries, which physiologically mimics a blockage. Its presentation will therefore mimic acute coronary syndrome, but it's not caused by obstructive coronary artery disease. The clinical picture consists of symptoms and diagnostic testing consistent with acute coronary syndrome, like ST changes on EKG and elevated troponin levels. However, coronary angiography will show no blockages. A key feature is abnormal ballooning of the left ventricle, particularly in the apex. It's fairly rare, in fact, it's new on the most current blueprint, but it most commonly presents in postmenopausal age women, and while it can be associated with complications, most patients will fully recover. Okay, before we jump into some practice questions, let's talk briefly about evaluation and management. Remember that echocardiogram is the primary diagnostic test. It allows us to assess heart size, wall thickness, chamber function, and ejection fraction, pretty much everything we need to know. Treatment is really focused on managing symptoms. We use things like beta blockers for hypertrophic, diuretics for fluid overload and dilated. We want to treat the underlying cause in restrictive, and then supportive care in stress. Now, I know this is a really busy slide and I'm not going to go over it in great detail. That would be some pretty high level questions being asked. However, when we talk about conditions that lead to heart failure and heart failure management, we're mostly talking about symptom and supportive care management. And these are the classes of medications that are used for that. And you should be familiar with when and how they are used. So use this as a reference, maybe take a picture of it and use it as you're studying, but I'm not going to spend a whole lot of time on it right now. All right, now that you know everything you need to know about cardiomyopathy, let's go back to those practice questions. Now I'm going to put the questions up, but I'm not going to read them again. What I encourage you to do is hit pause, take the time to read it, and come up with your answer, and then we'll go over them together. Let's get started. Well, of course, now you know the answer to be restrictive cardiomyopathy. That might have felt a little easy after doing this review, but before you did the review, it might not have come so easily. Let's take a look. Right off the bat, we see she has amyloidosis and symptoms of heart failure. We see physical exam symptoms consistent with this as well, especially that S4 gallop. And a big key here is that echo showing thickened ventricular walls with diastolic dysfunction. Even if you didn't remember that restrictive cardiomyopathy is associated with diastolic dysfunction, you already have plenty of information here to make the correct diagnosis. And maybe initially you were able to narrow it down to restrictive cardiomyopathy or heart failure, and that's where that amyloidosis really is key. Remember, it's one of the infiltrative diseases. Those amyloid proteins infiltrate into the cardiac muscle tissue, making it stiff, restrictive, like blowing up that rubber balloon. All right, let's move on to the next question. Remember to pause your screen and take the time you need to read and answer the question. This one might have been a little more challenging, but the answer is beta blocker. You were probably able to conclude that this patient had hypertrophic cardiomyopathy. It was a young athlete who collapsed. There was a family history of early sudden cardiac death, and there was the classic murmur that intensified with Valsalva maneuver. However, PANCE questions are not always this straightforward. Formulating the most likely diagnosis is the most common task category covered, but managing patients is also heavily covered, and that includes clinical intervention and pharmaceutical therapeutics, like this question. Statins don't really have a role in management here, and then ACE inhibitors, nitrates, and loop diuretics can all worsen left ventricular outflow obstruction, which is often a part of hypertrophic cardiomyopathy. All right, our final question. You know the drill. Hit pause, read the question, and see if you can come up with the answer. And the answer is dilated ventricular chambers with reduced ejection fraction. We know she has dilated cardiomyopathy because she's presenting postpartum with signs and symptoms of heart failure, which is not normal. And remember, pregnancy is one of the common causes of dilated cardiomyopathy. So if you see pregnancy postpartum and then signs and symptoms of heart failure, think dilated cardiomyopathy. We can also take a look at the other answer choices and rule them out. So, septal hypertrophy is a finding in hypertrophic cardiomyopathy. Ventricular wall thickening is seen in restrictive cardiomyopathy. Pericardial thickening is seen in constrictive pericarditis, which she does not have signs and symptoms of or a common presentation for that. And then regional wall motion abnormalities are more consistent with ischemic heart disease. All right, guys, that concludes our review of cardiomyopathy. Make sure you come back and check out other reviews as we post them. Make sure you also check out the website, allthingspac.com. We have some of the best and most affordable resources for PA students that I'm super proud of. We have our Qbank with over 1,000 questions. We're adding more questions all the time. We have PANCE Points, which is our new review course. It is a bullet point style comprehensive review of every topic on the PANCE Blueprint. It's everything you need to know in a concise, easy to read format. It's a perfect companion for our Qbank. These programs have a dashboard. You can keep track of your progress. You can just answer questions. You can sort questions by system or category or EOR. You can take quizzes. You can even take a full length mock PANCE exam. Just make sure you check it out. All right, see you next time.